Welcome to the deep dive. Imagine walking into a massive, brilliantly illuminated hospital wing. You reach out, you flip a switch on the wall, and instantly, a bank of overhead lights goes dark. You flip it back up, and the lights blaze back to life. The most natural, hardwired human instinct is to conclude that the switch controls those lights.
Right. It's immediate. It's variation in tandem.
Exactly. But if you are the structural engineer, or in our case, the medical professional, tasked with maintaining the integrity of public health, knowing the switch and the light vary in tandem just isn't enough. You need to understand the hidden wiring behind the drywall. You need to know exactly which wire to cut to prevent an electrical fire, or which pillar is purely decorative versus a load-bearing wall supporting the entire structure.
That structural engineering metaphor really gets to the heart of what we're analyzing today. We're looking at causal inference. We're moving beyond the simple observation that two things happen at the same time to actually mapping the hidden functional wiring of disease and health. I mean, the light switch analogy is a great starting point, but in clinical reality, we're rarely dealing with a single switch and a single light. We're dealing with millions of interconnected circuits, overlapping biological systems, and frankly, decades of latency.
And to you listening, whether you are a medical student prepping for boards, a junior doctor evaluating a new clinical guideline, or a public health trainee designing a population-level intervention, you are that structural engineer. You have to distinguish between a decorative correlation and a load-bearing cause.
Because intervening on a correlation just wastes resources. Intervening on a true cause actually alters outcomes and saves lives.
Right. So today we're using Chapter 5.14 of the Oxford textbook of Global Public Health as our primary structural spine. We are unpacking the foundational concepts of causation as laid out by Catherine Hoggett, Sander Greenland, and Tyler Vanderweel.
Our objective here is to clarify these frameworks, strengthen your epidemiological reasoning, and support your active reading of the chapter. We highly recommend reading Chapter 5.14 alongside this deep dive. Think of us as your companions to the text, here to give these concepts three-dimensional context so they become second nature on the wards or in the field.
Okay, let's unpack this. Let's start with the cognitive trap of the light switch. From early childhood, we're conditioned to equate variation in tandem with causation. If I drop a glass, it shatters. If I touch a hot stove, I get burned. It's an incredibly efficient heuristic for surviving everyday life.
It is, but when you look at the history of public health, relying on that intuitive heuristic is profoundly insufficient. And it's often dangerous.
Dangerous how?
Well, it's insufficient because it relies on naive induction. The philosopher David Hume pointed this out way back in 1739, and it remains a cornerstone of modern scientific rigor. He basically said there is absolutely no deductive way to prove causality.
Which is a tough pill to swallow.
It is. Deductive reasoning implies absolute mathematical certainty. Like, if A is true and B is true, C must inherently be true. But in biology and epidemiology, we can never observe every possible instance of an exposure and an outcome across all of time, space, and genetic variation. Therefore, causal inference can only ever be a speculative inductive process.
That is a massive paradigm shift from how basic science is often taught. The idea that we cannot deductively prove causality sounds almost, scandalous to someone looking for hard clinical rules.
Yeah, it means that every piece of medical knowledge we operate on is, strictly speaking, provisional. It demands profound intellectual humility. We gather observations, we design increasingly sophisticated observational and experimental methods, and the output is never absolute proof.
It's a working theory.
Exactly. The output is a working theory of cause and effect. I mean, the history of medicine is a graveyard of established facts that were later overturned by better methods and new evidence. You must cultivate a systems thinking mindset, remaining constantly prepared for new data to update your causal models.
So if we accept that we cannot deductively prove anything, we're still left with the reality of having to act, right? A clinician still has to prescribe medication. A public health official still has to implement policy. So what does this all mean? How do we reconcile the fundamental uncertainty of causal inference with the necessity of rational decision-making?
By drawing a very strict, impenetrable line between the two. The text is very clear on this. Causal inference and rational decision-making are two entirely different domains.
Okay, break that down for me.
Sure. Causal inference is an objective, mathematical, and biological pursuit. It simply asks, does intervention X cause outcome Y? Rational decision-making uses that inference as merely one input among many. Decision-making is inherently messy because it requires weighing financial costs, resource allocation, and ethical considerations in the face of equivocal evidence.
Right. The history of smoking bans in bars is a prime example of this division.
It absolutely is.
Yes. When those policies were being formulated, policymakers weren't waiting for deductive absolute proof that environmental tobacco smoke caused lung cancer in bar staff. The causal inference, the epidemiological data showing an elevated risk, that was only half the equation.
Right. The decision-making process required an economic and societal calculation. They had to determine that the perceived health benefit of preventing respiratory disease and cancer in workers vastly outweighed the negative economic impact on the hospitality industry.
Hormone replacement therapy, or HRT, for postmenopausal women is an even sharper clinical example of this divergence, isn't it?
It's a perfect example. Epidemiological evidence might suggest that prescribing HRT prevents heart disease in a specific demographic. That's the causal inference.
But HRT also carries serious risks.
Exactly, including an increased risk of certain cancers or stroke in specific subpopulations. So the clinical decision to prescribe HRT cannot be made solely on the causal link to cardiovascular prevention. The decision must incorporate the shifting costs and competing risks.
And those competing risks interact with individual patient values, family history, and risk tolerance. As a clinician, you are constantly navigating these two domains. You evaluate the epidemiological inference to understand the load-bearing capacity of the data, and then you act as the architect, working with the patient to decide if that is the intervention that aligns with their clinical goals.
That's beautifully put. Now, to build those causal theories in the first place, we have historically relied on a series of guideposts.
Like Koch's postulates.
Exactly. For infectious diseases, we had Koch's postulates in the late 19th century. The idea that a microorganism must be found in abundance in all organisms suffering from the disease, but not in healthy organisms, and so on. But as public health transitioned toward chronic diseases like cancer and cardiovascular disease in the mid-20th century, Koch's postulates completely fell apart.
Because you can't isolate a single microorganism for lung cancer or heart disease. The latency periods are decades long, and the exposures are multi-causal.
Right. This shift necessitated a new framework, which brings us to Sir Austin Bradford Hill.
Oh, yes. Anyone who has taken an introductory epidemiology course has memorized Bradford Hill's name. But there's a pervasive myth in medical education here that we really need to dismantle immediately.
What's fascinating here is the myth of Hill's criteria. In his landmark 1965 address, which emerged around the same time as the first U.S. Surgeon General's report on smoking and health, Hill laid out 9 points to consider when evaluating an association.
9 points.
Yes, and he was incredibly explicit that these were not a checklist, they were not rigid criteria, they were not necessary conditions for causation to be inferred, yet they are almost universally taught and misapplied as a diagnostic checklist for causality.
Which is wild.
Yeah.
Treating them as rigid criteria actually harms the inferential process. Let's deconstruct these 9 guideposts precisely as Hoggett and Greenland present them to understand why they are heuristics rather than laws. Let's group them conceptually. Start with the instinct to look for overwhelming signals, strength and consistency.
Okay, the logic behind strength is that a massive association, say a risk ratio of 10 or 20, is much harder to explain away by unmeasured confounding than a weak association. If a new occupational exposure is associated with a 20-fold increase in a rare cancer, it commands attention.
But the magnitude of an association does not guarantee causality. We can easily mistake the passenger for the driver.
Exactly. Look at the textbook's example regarding the association between birth order and Down syndrome. If you look purely at raw, unadjusted data, there is a very strong, undeniable association between being a later-born child, say the 4th or 5th sibling, and the incidence of Down syndrome.
The strength of the association is massive.
Massive. But birth order is not the causal mechanism. Maternal aging is the true cause. Maternal age happens to be strongly associated with infant birth order, acting as a classic powerful confounder.
And conversely, small associations can be definitively causal. Environmental tobacco smoke has a relatively small risk ratio for lung cancer compared to active smoking, but the consensus is that it is causal because the mechanism is understood. So if strength isn't a reliable law, our natural instinct is to look for repetition. That brings us to consistency. If we see it across multiple populations in London, Tokyo, and New York, we assume it must be a universal biological law.
Warning. Consistency can be a trap, perhaps the most dangerous trap of all 9 points. The absence of consistency doesn't mean there is no causal effect. An agent might only operate in highly susceptible genetic subpopulations. But far more dangerously, the presence of consistency does absolutely nothing to rule out shared systematic bias.
A consistently wrong answer is still a wrong answer.
Perfectly said. The beta-carotene paradox is the ultimate cautionary tale here.
Walk us through that.
For years, massive, well-conducted observational cohorts consistently showed an inverse association between beta-carotene intake and various cancers. People with higher beta-carotene levels had lower cancer rates. The finding was incredibly consistent across multiple populations and different analytical teams.
But when we finally put it to the test in randomized controlled trials,
The trials utterly refuted the observational data. Beta-carotene supplements did not protect against cancer. In some high-risk groups, like smokers, they actually appeared to increase harm. The consistency across the observational studies wasn't a consistent biological truth, it was a consistent sociological bias.
because health-conscious people who ate diets rich in beta-carotene also engaged in a matrix of other health-promoting behaviors.
Exactly. Exercise, lower alcohol consumption, better sleep. The observational designs were merely capturing the consistent echo of a healthy lifestyle, not the isolated effect of the molecule.
Let's move to the next guidepost. Specificity. The historical idea was one cause, one effect. The pneumococcus bacterium causes pneumonia.
Specificity is highly limited today. We know biology is vastly more pleiotropic. Smoking doesn't specifically cause lung cancer. It causes systemic vascular inflammation, leading to heart disease, stroke, and a dozen other malignancies. However, the concept of specificity has evolved into a brilliant analytical tool known as negative controls.
This is a vital concept for anyone designing a study. Detail the text mammogram example for us. How is a negative control applied?
Let's say you are analyzing observational data to determine if screening mammography reduces breast cancer mortality. A valid critique is that patients who volunteer for regular preventative mammograms are likely fundamentally different from those who do not. They might have better healthcare access, better diets.
So the apparent protective effect of the mammogram might just be confounding by healthy behaviors.
Right. How do you test that hypothesis using specificity? You look at whether getting a mammogram is associated with lower mortality from completely unrelated conditions.
You look at colon cancer or lung cancer mortality in the same cohort, because a breast mammogram cannot physically, mechanically alter the trajectory of colon cancer.
Precisely. If your data shows that the women getting mammograms have lower breast cancer mortality, but also have significantly lower mortality from colon cancer, lung cancer, and cardiovascular disease, your specific effect has vanished. It heavily implies a generalized healthy lifestyle bias.
But if the mammogram is specifically associated only with lower breast cancer mortality and shows a null association with unrelated diseases, it dramatically strengthens your causal inference. It's a way of stress testing your own data for hidden biases.
Exactly. Moving on to temporality and biological gradient. Temporality simply dictates that the cause must precede the effect. Out of all 9 of Hill's considerations, this is the only one that is universally accepted as a strictly necessary condition.
You cannot violate the arrow of time.
You cannot. Though in modern chronic disease modeling, temporality is incredibly difficult to isolate mathematically. If X and Y vary over time, they might have a longitudinal feedback loop. Take poverty and severe mental illness.
Poverty might precede and exacerbate mental illness, which in turn impairs functional capacity, leading to deeper poverty.
Right, taking a cross-sectional slice of data makes isolating the precise temporal initiation nearly impossible. Now, what about biological gradient, or the dose-response relationship?
The intuition here is that more exposure equals more disease.
It's an intuitive assumption, but not always linear. Epidemiologists caution against assuming trends must be monotonic. Many physiological responses exhibit non-monotonic U-shaped or J-shaped curves.
Vitamins are the classic clinical example.
If you look at vitamin D, very low levels increase the risk of pathology. As the dose increases to a moderate level, the risk decreases. But if you push the dose into massive supplementation, it becomes toxic and the risk spikes again. That is a biological gradient, but it's not a simple straight line. And a perfectly smooth gradient doesn't prove causality either.
Because it could just be an uncontrolled confounder mapped onto the outcome.
Precisely. The final grouping includes plausibility, coherence, analogy, and experimental evidence. Plausibility asks if the association makes biological sense with our current scientific knowledge. Coherence dictates it shouldn't violently conflict with known natural history.
These sound entirely reasonable, but they contain a fatal flaw.
They do. Our current knowledge can be profoundly wrong. The miasma theory of disease is the ultimate historical proof.
Oh, the bad air theory.
Yes, in the mid-19th century, it was entirely plausible and coherent with miasma theory to conclude that foul air caused cholera in urban slums. The epidemiology perfectly aligned with the biological dogma of the day. It was highly plausible, but entirely lethally wrong.
Jon Snow had to advocate for waterborne transmission, which was deemed entirely incoherent by the medical establishment. There's a more modern example in the text regarding lung cancer and smoking that illustrates this too.
The shallow versus deep inhaler paradox. Early researchers observed a highly counterintuitive phenomenon. Smokers who were shallow inhalers actually presented with higher rates of lung cancer than deep inhalers.
Which was viewed as utterly incoherent at the time.
Completely. The assumption was that drawing carcinogens deeper into the lungs should cause more damage. This incoherence was actually used to argue against the causal link between smoking and cancer.
But the epidemiology was right and the biological assumption was wrong.
Decades later, histological research revealed that the specific cells most vulnerable to the primary carcinogens in smoke were densely concentrated in the upper respiratory tract, not the deep alveoli. Shallow inhalers were perfectly bathing the most susceptible cells in concentrated smoke.
What was initially dismissed as incoherent became a profound biological insight, which is a humbling reminder for anyone reviewing literature. If your rigorous data conflicts with current clinical dogma, do not immediately assume your data is flawed. The dogma might be what requires an update.
As for experimental evidence and analogy, we briefly cover human and animal limits due to ethics and practicality. An analogy is bound strictly by human imagination. To summarize this section, these points generate hypotheses. They do not prove causation. They act as values rather than objective inferential tools.
Okay, here's where it gets really interesting. If we discard the checklist approach, how do modern epidemiologists actually engineer these models? This brings us to the formal architecture of counterfactuals, or the potential outcome framework.
This represents a seismic shift. It frames causal inference strictly as a prediction problem. We are trying to mathematically predict what an outcome would be under one specific action versus a very specific alternative action.
To build this, the text outlines three mandatory components. First, a target of interest. Second, a list of possible interventions like x0 by 1. And third, an outcome measure, y. Let's make this concrete with the stool blood kit example from the textbook.
All right, let's walk through it step by step. Our target is a 50-year-old patient. We have two possible mutually exclusive interventions. Action X equals 1 means the clinic supplies him a home sampling kit for colon cancer screening. Action X equals 0 means the clinic does nothing. No kit is supplied.
And our outcome measure y is binary. Y of 1 means he dies of colon cancer by age 60 if sent the kit. Y of 0 means he dies of colon cancer by age 60 if not sent the kit.
The potential outcome framework forces us to conceptualize an outcome variable for every possible treatment. But here is the massive fundamental brick wall we hit, the missing data problem.
We can only ever observe one of those potential timelines.
Exactly. If we supply the kit, we observe y of 1. But the moment we take that action, y of 0, what would have happened if we hadn't supplied it, becomes contrary to fact. A counterfactual, it is permanently unobservable.
So if the entire foundation of determining a true causal effect relies on an unobservable alternate timeline, how is this useful?
Because it forces us to rigorously define the contrast. This brings us to a crucial differentiation: the difference between an effect and an association. A foundational rule here is that an action cannot be inherently causal without an explicit reference condition. An effect must contrast outcomes for two different actions in the same single target.
Let's look at the devastatingly clear example the text provides regarding antidepressants and suicide.
A severely depressed patient is prescribed an outpatient antidepressant. A month later, the patient tragically commits suicide. Did the antidepressant cause the suicide?
Under the potential outcome framework, that question is incomplete. What is the alternative timeline we are contrasting against?
Exactly. If our reference condition is no intervention, meaning the clinician sent the patient home without a prescription, it's highly probable he would have died anyway.
So compared to no prescription, the drug didn't cause the suicide, it just failed to prevent it.
But what if the alternative action, our x equals 0, was immediate inpatient psychiatric hospitalization? It is highly probable that in that counterfactual timeline, the hospitalization would have saved him. So in that specific contrast, outpatient prescription versus hospitalization, the decision to prescribe the outpatient medication did cause the suicide.
Wow. The exact same physical action has a completely contradictory causal meaning depending entirely on the specific alternative action we construct. Effects must contrast outcomes for two different actions in the same single target. But we're still stuck with the missing data problem. We still can't observe the counterfactual.
Because we cannot observe the true counterfactual, we must use an entirely different group, a control group, as a substitute reality.
Let's illustrate this substitute reality with the Florida helmet law example from the textbook.
In July 2000, Florida weakened its motorcycle helmet law. To find the true effect of that law change on crash fatalities, we want to know the 2001 fatality rate if the law hadn't changed.
But 2001 Florida, under a strict law, is our unobservable counterfactual. It doesn't exist.
Right, so we use the 1999 fatality rate before the law changed as a substitute.
But this shift from comparing the same group under two conditions to comparing different groups or different times is the shift from a measure of effect to a measure of association. We are hoping the association mirrors the true effect.
If we connect this to the bigger picture, this brings us to the precise mathematical definition of confounding. Confounding is literally the mathematical difference between the measure of association we can see, the 2001 versus 1999 comparison, and the true measure of effect we want to see.
Why would 1999 differ from the 2001 counterfactual?
Weather patterns might have been different, leading to more riding days in 2001. The economy might have boomed, bringing more inexperienced riders onto the roads.
All of these are confounders. Epidemiologists use stratification and standardization to adjust for measured confounders, trying to make the 1999 group look identical to 2001.
But unmeasured confounders always threaten the validity of the inference, which is why the randomized control trial is revered. Randomization forces the control group to be a statistical mirror of the intervention group's missing counterfactual.
But we can't randomize everything. We rely on observational data. And to navigate that, modern epidemiology uses directed cyclic graphs, or DAGs.
DAGs are visual tools, nodes and arrows. They force you to explicitly state your assumptions and show you what to adjust for. But more importantly, they show you what not to adjust for, avoiding analytical traps like collider bias.
Let's use the obesity survival paradox in heart failure as a clinical example of collider bias.
We know obesity causes heart failure, but observational data often shows that once admitted to the hospital with acute heart failure, obese patients actually have better survival rates than normal weight patients,
leading some to suggest fat is protective in acute illness.
But let's map the DAG. Both obesity and mortality independently cause a third variable, hospital admission. A collider is a node where two arrowheads meet.
So if you conduct your study only on patients admitted to the hospital, meaning you condition on the collider, you induce a spurious association. The normal weight patients are only in the hospital because they have incredibly severe underlying disease forcing them there despite their normal weight.
The collider bias makes obesity look protective when it's just a selection artifact. DAGs also clarify mediation. A mediator lies directly on the causal pathway. If a diet lowers blood pressure and blood pressure lowers heart disease, adjusting for blood pressure blocks the very mechanism you're studying.
This complexity is perfectly conceptualized by Kenneth Rothman's sufficient component cause model, recognizing that most public health problems emerge not from single agents, but from interacting systems.
The pie chart model. A sufficient cause is a complete pie that inevitably produces disease. The component causes are the slices. For lung cancer, one pie might be genetic susceptibility, smoking, and asbestos.
No single slice is enough on its own.
Exactly. Another pie for lung cancer might be genetic susceptibility, radon, and a virus. Genetic susceptibility is in both, making it a necessary cause. But smoking is just a component cause. You don't have to eliminate every slice to prevent disease. Remove the smoking slice from pie 1, and that specific mechanism is broken.
Which transitions us perfectly to the final section, translating inference to policy in the real world. Academic discussions often focus on unrealistic, unhelpful questions.
The textbook outlines a hierarchy of policy questions. Level 1, the irrelevant questions. What if we eliminated lung cancer? The text calls this outcome removal.
Why is that irrelevant?
Because it ignores competing risks. Take the myocardial infarction example. If a patient suffers a fatal MI at 54, and you ask what his survival would be if we prevented it, it depends entirely on how we prevented it.
Did we implement diet and exercise in his 20s?
Right, which lowers his risk for cancer and stroke too. Or did we just use an aggressive mobile ICU at the time of the heart attack? In that kind of case, he survives, but remains at massive risk for a secondary MI. You cannot just remove the outcome. You have to define the intervention.
Level 2 is slightly better. Risk factor removal. What if we eliminated smoking or lowered BMI? The BMI debate in the text is fascinating.
BMI is an intermediate outcome, not an intervention. Lowering a BMI to 24 via a healthy diet has a fundamentally different mortality outcome than lowering it to 24 via chronic amphetamine use or gastric bypass.
You cannot unambiguously define a causal effect of BMI without defining the specific intervention used to change it. The same logic applies to race and sex. Treating non-manipulable characteristics as causes is analytically unhelpful for policy. You cannot feasibly intervene to change someone's race.
Exactly. You intervene on the mechanisms driving the disparity, like systemic bias or environmental exposures.
Which brings us to the highly relevant Level 3 questions. What if we funded a specific smoking cessation program in a motivated group?
A feasible intervention. But this raises an important question. What happens when people don't comply?
There's a difference between treatment assigned, what policymakers control, and treatment received, which is what the patient actually does.
This is why we use intention to treat analysis. It evaluates the policy based on the treatment assigned, absorbing all the messy compliance failures into the data, giving a realistic estimate of public health impact.
And finally, generalizability, the difficulty of applying past study populations to future target populations, effect measure modification.
The underlying genetics, environments, and infrastructure of a future population will interact with the intervention to modify the effect. We are always projecting a shadow into the future based on the light of the past.
Causal inference is a synthesis of evidence. No single observational study establishes causality. Science informs policy, but policy must also address economics, ethics, and human behavior. Before we sign off, I want to leave you with a provocative thought based on the text. We've learned today that to measure an effect, we absolutely must define an alternative, counterfactual intervention. But think about this. If our causal models rely entirely on the specific alternatives we choose to imagine, how much do our own cultural, clinical, or institutional biases limit the very questions we ask? Are there life-saving interventions we fail to prove simply because we lack the imagination to define the right counterfactual? Let that sit with you.
That is a critical limitation of the field to keep in mind.
Before we sign off, let's lock this in with a rapid-fire review. I'll ask the question, give you a brief pause to think, and then provide the answer. Question 1. Which of Hill's considerations is the strictly necessary condition for asserting causality? Temporality. The cause must precede the effect. Review the Hill's considerations section for consolidation. Question 2. Comparing Florida's 2001 motorcycle fatality rate after a law change to its 1999 rate before the change yields what type of measure? A measure of association. It is used as a substitute for a measure of effect. Review the confounding and measures of association section. Question 3. In the potential outcome framework, why is it impossible to directly observe the causal effect in a single individual because of missing data? We can only observe the outcome of the treatment actually received. The alternative is counterfactual. Review the potential outcomes and counterfactual causality section. Question 4. What is the mathematical definition of confounding according to the text? The difference between the measure of association, which we observe, and the true measure of effect, which it is intended to represent. Review the confounding and measures of association section. Question 5. Why is it problematic to define the causal effect of BMI on mortality? Because BMI is an intermediate outcome, not an intervention. The effect on mortality depends entirely on how the BMI was lowered, like diet versus amphetamines. Review the removing risk factors section. Here are the details of this episode.
Causation and causal inference. Byline. When does an association become a cause? Exploring the logic, philosophy, and methods that allow epidemiology to move from correlation to confident action. Episode description. In this episode, Medlock Holmes steps into one of the most fundamental questions in public health. What does it mean to say that something causes disease? In this episode, Medlock Holmes steps into one of the most fundamental questions in public health. From early infectious disease models and Koch postulates to Bradford Hill's criteria and modern counterfactual reasoning, we unpack how causal thinking has evolved. We explore the difference between association and causation, and why that distinction matters profoundly for public health decision-making. Holmes guides us through the architecture of causal inference, confounding, bias, mediation, and effect modification. We examine how randomized trials approximate the counterfactual ideal and why observational studies must rely on rigorous design and analytic discipline. Holmes guides us through the architecture of causal inference. We also introduce directed acyclic graphs, DGs, as visual tools for clarifying assumptions and avoiding analytic traps such as collider bias. Finally, we consider multi-causality and the sufficient component cause model, recognizing that most public health problems emerge not from single agents, but from interacting systems. Holmes guides us through the architecture of causal inference. This episode provides the intellectual scaffolding for everything that follows in epidemiology. Without causal inference, there is no credible intervention. Holmes guides us through the architecture of causal inference. Holmes guides us through the architecture of causal inference. Key takeaways. Holmes guides us through the architecture of causal inference. Association alone does not establish causation. Holmes guides us through the architecture of causal inference. Bradford Hill's considerations guide but do not dictate causal judgment. Holmes guides us through the architecture of causal inference. Counterfactual thinking underpins modern epidemiology. Holmes guides us through the architecture of causal inference. Confounding and bias threaten valid causal inference. Holmes guides us through the architecture of causal inference. Randomization strengthens internal validity, but is not always feasible. Holmes guides us through the architecture of causal inference. Most diseases arise from interacting component causes rather than single agents. Holmes guides us through the architecture of causal inference. Causal inference is foundational to ethical and effective public health policy.